everybody. My name's Simon Thompson. I'm a pain physician, Basildon and Thurrock University Hospital. And I treat patients with chronic long-term pain and other chronic long-term conditions. And I use, amongst my armamentarium, implantable neuromodulation devices. But today I'm going to talk about spinal cord stimulation for chronic neuropathic pain. So first of all, my disclosures: I act as a consultant for the British Standard Agency, Kite Mark. I've been on various medical advisory boards for Medtronic and Boston Scientific. And I've had some honoraria for lectures and some expenses for various educational events. Now, I'm probably one of the only doctors here. I don't know whether that's true, but I don't think there are many, so I'm sort of in the lion's den, as it were. So I wanted just to give you a little bit of background. When it comes to thinking about pain, broadly there are two types of pain, and then of course a mixed version. What I'm actually going to be talking about is neuropathic pain. And it's described as burning, often shooting, electric-like, vice-like grip. And we collectively call these dysesthesias, unusual painful sensations. Tends not to be sensitive to NSAI drugs or opioids at regular dosage. It's caused by damage to the peripheral, autonomic, or central nervous system. You don't actually have to have a body to have pain felt in the body. You can have a stroke, and you can have intense burning pain in your body. You can have an amputation, and you can have phantom limb pain. Or you can damage the peripheral nerve system. And the typical systems are radiculopathies, sciatica, and after disc protrusion or lateral canal stenosis or an interruption to the blood supply to these nerves become neuropathic. And it doesn't matter how many times you do a surgery, it won't make any difference. Post-traumatic neuropathy after injuries, amputations, brachial plexus avulsions after a motorcycle accident avulsing the nerve roots out of the neck, as I said, amputations, trauma to the soft tissues and the sensory nerves within the skin. Diabetic polyneuropathy, burning feet, shooting pain, walking on marbles, shingles, post-viral neuropathies, complex regional pain syndromes, typically injuries that after a trivial incident, often in young people, spreading of pain to involve the whole limb or even other parts of the body. And then post-surgical neuropathies, after surgical procedures, breast operations, groin operations, gynecology operations, knee operations. Probably about between 0.2 and 5% of all surgeries result in severe neuropathic pain. Then there's nociceptive pain. This is what kind of brings you back into the more normal, if you like, pain. Because pain should be useful. It should be a warning to take your hand off the hot plate. But also it becomes useless after a while, such as in chronic arthritis. And these tend to stimulate, if you like, or activate normal pain-sensing pathways that project both to the somatic sensory parts of the brain, where is it, how is it felt, and also to the emotional centers of the brain as well. Nociceptors are fairly non-specific nerve endings found in most tissues, and are actually sensitive to different stimuli. There's a remarkable amount of specificity, even amongst pain signals, right out in the periphery, to mechanical, thermal, chemical, or agents. And there is somatic pain, and then there's a pain of visceral organs, such as distension of visceral organs. So certain examples: bone pain, arthritis pain, cancer pain, which is often mixed, nociceptive, and if it's invading nerves, or damaging the nervous system in the periosteum, giving people mixed neuropathic and nociceptive pain. Typically, it's elicited by the tissue injury rather than the nerve injury. Chronic pain is actually a really big problem, completely unrecognized by our system of healthcare system, not just the UK, but elsewhere in Europe. Actually, the figure is staggering. If you look at the epidemiology of patients, 19% of Europeans in a widely accepted epidemiology study fulfill the definition of chronic pain that affects activities of daily living. And a third of them it's severe, and a third of them it's probably neuropathic in origin. So about 10% of patients with chronic pain, it is neuropathic pain. And it's varies slightly around European countries according to the survey, which actually, to be honest, is probably an underestimate because it was a telephone survey, and not every person will be, such as the elderly, tend to be in care homes and so on. So if you look at the UK, it's estimated that about 800,000 people suffer from chronic neuropathic pain. Neuropathic pain has a big impact. If you look at quality of life scales and using things like Euroqol, you're able to actually compare the impact of that disease on quality of life. And you can do that across spectra of diseases. A study I was involved in, which we'll come to later, which is on the failed back surgery syndrome. These are patients with chronic neuropathic pain. At entry, these patients had a mean EQ5D of 0.14. Now, 0 is death, and 1 is perfect health. So if you look at the general population, hopefully you will be somewhere above 0.8, probably waning fast. But other conditions, as you can see, such as diabetic neuropathy, mixed neuropathic pain, and central neurogenic pain, such as after stroke. So it's a big impact. What about the sort of costs, if you like, on the NHS? And so this is just exemplary data, showing that if you grade people's severity, if you like, of neuropathic pain, and then you look at the healthcare utilization, and it's probably would go without saying, but here are the facts to show that those people with more neuropathic pain consume essentially more NHS resources. Compare almost twice as much, if you like, as you go up the severe spectrum. So really I've presented to you the idea of what chronic pain might be, specifically focusing on neuropathic pain and trying to talk to you about the impact that makes both individually and perhaps on healthcare systems. So there's lots of room for improvement. About 38% of Europeans with chronic pain report that their pain is not adequately managed. That comes from the European Pain Survey. Over 50% of the sufferers wait 2 years or more before their pain is adequately managed. Only a quarter of the patients have ever been seen by a specific pain management specialist. In the Pain in Europe study, it was actually only 2%. The lifetime prevalence of suicide attempts in chronic pain patients is between 5 and 14%, with depression rates of up to a third. And nearly a third of patients claim that they have not been informed about new methods to better manage their pain. So the total burden of chronic pain across Europe can be estimated to be as high as 300 billion euros, consistent with chronic pain costing 1.5% to 3% of GDP. So it's a massive unmet need, and as we focus our healthcare economies on organ-based treatments, we're missing out on this big picture. So now I want to just talk to you about spinal cord stimulation and how this can help a subset of patients. So spinal cord stimulation is, as we heard earlier, is the electrical stimulation of nerves within the spinal cord to provide useful clinical benefit through the modulation of what is already abnormal sensory processing within the peripheral autonomic and central nervous system by means of implantable devices. So our little cartoon, there are 3 elements of it. You have a pulse generator, which has got its own power source and is essentially a small computer that's connected by a series of leads to a number of electrodes that are placed within the epidural space, all percutaneously with minimal intervention surgery. And the pulse generator can either be placed in a pocket of under the skin in the fat in the tummy or in the back pocket, and the patient then has a handheld controller that can, after programming, they can go between different programs and driving the stimulation where they need it, whether it be into the chest, into the back, into the legs, down into the feet, into the perineum. I thought it might be actually helpful, rather than just talking about stats, just to actually meet a typical patient. And so this is one of my patients, Sarah. And I do about 3 spinal cord stimulation procedures a week. So this is just somebody who I happen to be teeing up for another article. So that's why I went into her history. So she was actually referred to me as a tertiary patient from another pain management centre, and I saw her on the 7th of January 2011. She was 36 years old and an ex-self-employed publican, but she had had to stop work due to pain, and she then was living with her mum and was mostly housebound. Her history was that at 17 she developed low back pain, and that was treated with laminectomy. This is one of the common misconceptions, is that chronic pain is a condition of the elderly. It is, but it's not true. The average age of a chronic pain patient in the clinic is in their 40s. At 32 years old, back and right leg pain, treated with 2 lumbar steroid epidurals, settled down. 2 years later, further episode of right leg and back pain, but it didn't respond then to the steroid epidurals and root injections, or even the facet joint injections. The clinician was looking for another generator of pain. So she'd had symptoms for 15 months, and it was described as a deep inside toothache right pain down the whole of her right leg and into her ankle, with electrical shooting components. As much of her pain distribution was felt in her right leg as in her back, and she rated her pain, where 0 is no pain, 10 is the worst pain you can imagine, oscillating regularly between 5 and 9 out of 10. She felt unable to work. She occasionally went out in the car. She had poor socializing and was tearful on occasions. So to her, she was facing a crisis, really. She had been well managed by a colleague of mine in another district. She was on anti-neuropathic medication, gabapentin, 3.6 grams per day. She was on 240 milligrams of codeine, as well as 200 milligrams of tramadol per day, paracetamol, diclofenac, and diazepam. Huge, great list, and yet scoring her pain between 5 and 9 out of 10. Clinical examination, abnormal straight leg raise, that's evidence of nerve root tension signs. She actually did have neurological change with weakness in plantar flexion, so she'd had some S1 root damage, and sensory testing revealed a numb foot. Her brief pain inventory was 8 out of 10, which is high, and her hospital anxiety and depression index was 5 and 9, which is normal. The MRI scan showed disc degeneration, annular tear, but no surgical target to decompress, if you like. So she has chronic S1 refractory neuropathic pain for 15 months. We in this world call that the failed back surgery syndrome. That means that they failed the algorithm of care that traditional surgical approaches, which is the traditional way of treating these patients with multiple revision surgeries, which we have shown does not work. That's the term that we use. So she had a multidisciplinary assessment in our clinic. She saw, obviously, a very trusted referring pain physician. She saw our neuromodulation combined psychology and physiotherapy person, and also the neuromodulation team nurse to fully explain about the therapy. And we then apply for funding, and this is where you guys are going to become so important. And we have to do this on an individual funding request, even though I've been doing this now for 20 years. So, what do we do? On the 28th of July, so, 6 months after referral, we obviously got the funding, which ain't too bad in the grand scheme of things, and we put in 2 leads, each with 8 contacts, and threaded them up to between T9 and T10 vertebral levels. This tends to be the magical area for back and bilateral leg pain. This is all done as a day case procedure under local anesthetic, with the patient awake. They've been basically met my team, and a therapeutic relationship is formed. They're then reviewed, so they're sent home the same day, and they're reviewed by telephone, and beforehand, various achievement goals during this trial period have been set out. So she was rung on day 3, 5, and 6. Obviously, it was helping her considerably. We're looking for at least 50% pain reduction and an improvement in function. We don't ask necessarily for them to be able to reduce medications, but during that week period, because they've been on them for so long and it's not easy to do, they have a little bit of, although it's a tiny wound, a little bit of wound pain. Anyway, we decided then to go ahead and implant, so we knew the therapy was going to work. And then we put the expensive bit in. So we put the implantable pulse generator in, which is a rechargeable device. This type of rechargeable device may last up to 25 years. And again, that's done as a day case. She's taught how to recharge it, taught how to reprogram it, and sent home and follow-up arranged. She has a wound follow-up, and then I've just seen her for a 3-month follow-up on the 18th of October, and how are you feeling? Fantastic. Off all the medication, except for the tramadol, because she has a dependency on that, and she is trying to slowly withdraw that without getting withdrawal symptoms. And she's now got a job, so she's self-employed nanny. So that's somebody whose, I think, life was probably going into long-term disability in the middle years of their life, and now is back to tax paying. I've had the privilege of being involved in what I suppose is one of the pivotal studies of spinal cord stimulation, and was very much used by NICE with other studies in order to demonstrate the effectiveness of adding spinal cord stimulation to usual care in patients with refractory neuropathic pain caused by the failed back surgery syndrome. And in that study, which is a ruthless, if you like, study design, we had really a big treatment effect from spinal cord stimulation. Nearly half of the patients achieving 50% pain reduction or more, and about 80% achieving 30% pain reduction, compared to the usual care group, adding medication, physiotherapy, psychological management, 9%. So it's a big treatment effect. And this, when it comes to devices, you've got to understand it's different to drugs. Drugs, you do large studies, tiny treatment effect, significance. Here, small numbers of studies, big treatment effect, hopefully significance. Does it last, I hear you ask? And here's just some evidence, again from the PROCESS study. This was on the SCS Continue group, and this is just looking at their SF36, which is obviously a measure of quality of life, and we see an improvement, and out to 2 years, the effect is still lasting. We did a UK appraisal, and I was part of the advisors for the University of Sheffield, an independent, if you like, evaluation of the evidence, and I was just one of their experts. And then we went through the NICE committee, and basically the NHS, as represented by NICE, confirmed that the evidence demonstrates this intervention is clinically effective, and what's more, it's cost effective. And this should be made available to patients who fulfill the criteria in the NHS. If you don't, you're wasting money. You're wasting the NHS's resources. And what are the criteria? Well, the criteria is that they've got to have chronic neuropathic pain for at least 6 months, despite appropriate conventional treatment. They've also got to have had some demonstration that a trial of spinal cord stimulation is effective. And we can either do that for a week using the definitive electrodes and then attaching the IPG, or it can be done with different electrodes, and then you whip them out and then list them for the procedure at another date. I think some of you who've been involved with NICE may know that a technology assessment is a rigorous process. You're surrounded by health economists, and they test that data to breaking point. And basically, spinal cord stimulation, when compared against conventional medical management or reoperation for chronic neuropathic pain and for complex regional pain syndrome, passed that test. And there should be no further argument about that. But there is. So recently we had the Croydon list from the Audit Commission. They used methodology that was around before the NICE guidance. They then brought it up to the present day and decided that from the evidence that they had before 2008, that spinal cord stimulation had low clinical value. So then we are then rocked again by these erroneous claims that spinal cord stimulation has no impact upon the health of these people. So there's these sorts of things that come out from different parts of the NHS are extremely damaging, and they propagate this myth, perhaps with unintended consequence of denying patients access to a cost-effective treatment. Let's look at the league table of NICE cost effectiveness. Often people look at spinal cord stimulation and say, oh, it's a very expensive treatment. Well, no, it's not. We've shown that on the horizon that NICE use, that it's not expensive, it's clinically effective. And if you compare it to some things like, for example, an asthma inhaler technology, it's actually almost comparable. Those two figures for 159 is the 11,000 is one of the figures that came out in the Sheffield HTA, but a further analysis by Rod Taylor using the same data set recalculated the ISA has been between £5,264. But broadly, it's well underneath the 30,000, and even if the gradient comes down to 20,000, it's well underneath that. And if you compare it to other therapies that are now reached greater than 90% penetration, such as implantable defibrillator therapy, it's a good value for money. So are we alone? Is there a gap around the world? And of course the answer is yes. It's probably thought that even in the USA, there's probably only about 10% of patients with chronic neuropathic pain get spinal cord stimulation. And in our country, it's probably 2 to 3% of those who would benefit from spinal cord stimulation actually get it. And you can see from different countries around Europe, it's all a similar lack of penetration. Although strangely, Belgium is slightly different. We did some work, my colleagues and I, on using the Freedom of Information Act, and we wanted to see whether there were how was spinal cord stimulation funded in different PCTs. So they were written to, and 42% declined to respond. 31% are still using individualized funding requests, which is really meant to be a temporary phenomenon in order to build I imagine, a cost-volume contract. 15% were using their own policy, sometimes informed, if you like, by the NICE guidance, but then making their own interpretations. They did that in our area. We showed them that it was illegal, and they've now backed off. And 12% were just simply referring to the NICE guidance. If you look at the variation in commissioning, if you like, of spinal cord stimulation, you'll see a massive variation across PCTs. There was a tendency for those who insisted on individual fundalized requests to be at the left-hand end, the lower instance rate, compared to those that had developed a policy on the right. So there's this massive variation. One of the things I want to talk to you about is that we don't even consider spinal cord stimulation until they've had 6 months of treatment. And of course, during that time, it would be reasonable to prescribe more, less invasive, if you like, treatments. But let's stop at 6 months. Let's not carry on. I mean, as you saw Sarah, who came through the system quite quickly, that was 15 months of treatment. But we're often getting patients of years of attempts at ineffective treatments, locked in a system. And indeed, from the PROCESS study, 2/3 of the patients had had 7 different independent treatments, modalities. Again, wasting resources. So in summary, I think you probably see that there is a massive variation in the prescribing of spinal cord stimulation across the NHS. There are damaging news can come out about unsubstantiated claims of low clinical value. They're both dangerous and they actually and cruel really, and prevent access to the technology. The technology has been proven by NICE to be highly cost and clinically effective. There's probably a large and unnecessary and avoidable spend on alternative treatments. And the intervention is only carried out, remember, when we've shown that it benefits a patient. So, what are we going to do? So the commissioning process needs to focus on the referral to treatment pathway for management of chronic pain. We actually need to develop a trigger, perhaps of recognizing neuropathic pain, recognizing the 6-month trigger, and then realizing that many of the other interventions that are being suggested are not best practice. We have a lack of SCS policy-led commissioning. It's very difficult to know who is meant to have picked up the guidance given out by nice. I think it's meant to be the primary care trusts. But all they've done is tended to try and obfuscate and try and get out of, if you like, their funding obligations. There needs to be attention to the areas of unnecessary spend, particularly in revision spinal surgery and in ineffective pain management strategies. A lot of these patients, they're not locked necessarily in pain clinics, they're locked often within primary care, often on ever-increasing doses of pregabalin and gabapentin. Appropriate and early intervention to pain management services, who again should be locked into a care pathway where spinal cord stimulation is recommended earlier by the referring doctor. The lack of commissioning focus on SCS will result in an increase in less cost-effective interventions with the associated budget impact unless we start to make these changes now. So if any of you are involved in the commissioning process, may I suggest that you do make spinal cord stimulation a priority for your 2012-2013 commissioning discussion, and that will ease some of your pains. That's the end of my little talk, but I just wanted to explain to you about the International Neuromodulation Society, of which I am president. We are very much interested in the development and the cutting edge, if you like, of new technologies. And we believe that a lot of these will actually be incorporated, much like spinal cord stimulation, into usual care in the future. So our next meeting is in Berlin. We had a very successful meeting in May 2011 in London. Our next meeting is in Berlin in 2013. You'd be very welcome to register. And our tagline is Neuromodulation, Technology Transforming Chronic Illness Management. So hopefully we are on message with you guys. So thanks very much. I think the idea of a 45-minute session, because hopefully I've only taken 20-25 minutes, is to allow some discussion. So I will try and answer any questions if anybody's got any. So thank you very much for your attention. So shall I ask you some questions? Oh no, here's one. Thanks.
It's not really a question. John Murray, Specialised Hospital Alliance, but I'm interested that your focus of attention has been on the primary care trust, because arguably this falls into the context of specialised pain management, which is within the Specialised Services National Definition set. And I don't know whether this will give you grounds for optimism or despair, but specialised pain management is likely to come under the auspices of the NHS Commissioning Board. Whether this particular technique will be seen as involving too large a patient population to remain with board, I guess is a moot point. But there should therefore be a relatively early opportunity to bring about a process of national convergence. So if you persuade them on the basis of the NICE guidance that this is indeed a cost-effective technique, then that should be generalised across the whole of England. Equally, if for some reason that I certainly wouldn't see in your presentation they decided against it, then of course it would be an extremely negative outcome. But I think that certainly from the point of view of Specialised Hospital Alliance, we see this as a tremendous opportunity for technologies of this kind being adopted in a more consistent and speedier fashion.
Oh, that's. I mean, in the past, I was involved a little bit with the specialised definition, and then the specialised commissioning services have had this variable thing where they've been in some parts of the country as an advisory role to PCTs, isn't it? And really what you're saying is that they're going to take over the funding, much like they did in West Midlands, I think.
Yes, I mean, the West Midlands has always been, I suppose, the most developed collaborative.
Yeah.
Area in the country, and there was something called the Carter Review in 2005-06, which tried to disseminate a similar approach across the whole of England, so 10 specialised commissioning groups were set up. But the willingness of PCTs to pool resource and expertise varied also between different parts of the national definition set. There's no doubt that specialised pain services were a definition which was almost entirely excluded from the remit of the specialised commissioning groups. But there's a clinical advisory group which is presently looking at that definition set in terms of what goes into a mandate from the Secretary of State to the NHS Commissioning Board to the board to commission directly. And our current expectation is that the vast majority of the definition set will go into that. Some things are going into early implementation from April 2012. Pain is not one of them, but pain is flagged up for adoption by the board when it comes into full effect from April 2013. So, I mean, it's a huge programme of work, but it's also a considerable opportunity. And I can understand why you've had the problems that you've had. I fear those problems are probably not going to go away in the next financial year because PCTs are under such pressure to balance their books before handing over to clinical commission groups. But maybe a better future will open up in April 2013. And in particular, it's very important that the costs associated with these treatments are captured by the board in its budget, so that you don't find they've got a responsibility, but the money is with the clinical commission groups.
Right. Is there anything I can do to...
We should have a conversation after this, because I'm probably boring everyone.
Yeah, okay, thanks, yeah. Yeah, I mean, I think one of the other problems we have is that we're talking about an investment in healthcare. Because although, you know, we can spend a little more and get all these QALYs back, we actually, after about, well, it depends on what time horizon and what technology, but between 3 and 7 years, it becomes a dominant thing. It becomes a cost-saving treatment. It actually, so that's the other problem when you've got funding cycles that only look at, what is it, 4 years now or 2 years? I don't know. But and that's our other problem, is people still see it as a you know, a cost to be borne now. Yeah.
On that point, do you think then that there's a little room perhaps for some financial innovation, so that one-off med device episodic nature of care perhaps can be seen more comparatively, although the ICER numbers do that, but in terms of making it more understandable at the front line, and comparing it to that sort of nice apportioned cost that you get with the drugs, because the list of drugs out there is very impressive, and of course that's apportioned very nicely and drip feed across the whole lifetime of that person's experience in the healthcare system.
Yeah, I mean, you know, Sarah's hopefully going to live for another 40 years. You know, I mean, I don't know whether, you know, you can carry on the cost of the budget depending on how many years they have the device or something like that, but that's going to be outside my expertise. So I'm just rambling, so I'm not going to do... Thank you, sorry.
Thank you, Dr. Thompson. I'm one of the clinicians myself. I'm a specimen over here. I'm a spinal surgeon, endoscopic surgeon like that, and I'm the clinical lead of orthopedics and the CAP service here. What I observe, I'm quite coming with what he had mentioned, that sometimes I believe that our view of allocating money on patients for back pain or pain as such is often very myopic, because what happens is the patients tend to go to GP many times. And the indirect cost of undergoing pain management is quite heavy, which we don't take into account under the normal PCT path. What tends to happen is the patients, of course, on disability allowance, and many of them don't go to work, or they are quite incapable of going for it. So what happens is the patient goes in circles for months and years. And what impact it has on the economy, that's what they can't comment on. But if I'm, as a clinician, I can make a diagnosis that this person is going to benefit a lot by going to you, I might be able to save a lot of money from the economy itself. What would you advise me as a clinician when and how I can detect a patient with PTSD?
Right. Okay, so obviously when it comes to costs, as clinicians, it's a very common thing. We often think about, you know, returning them to taxpayer and status, and, you know, reducing their dependency upon, you know, social care and disability living allowance. But the interesting thing is that the ICERs is all just about healthcare. So yes, there is out there another gain that society makes, if you like, from these interventions. As far as, you know, basically really what we're talking about is a care pathway. And one of my worries is this seeing back pain as being a sort of like a homogeneous health problem. And you know and I know that there is, you know, you can scratch the surface and you'll find 30% of people will have a lifetime instance of back pain which will have been disabling. Okay, we're not talking about putting spinal cord stimulators in 30% of the people. Okay, what we are talking about is those patients, particularly who've got neuropathic back and leg pain. And it's really trying to make that diagnosis early on to distinguish between essentially lumbago and arthritis-induced nociceptive pain of the back. I mean, I'm finding quite a lot of patients who have obviously got neuropathic pain because of spinal disease, but you know, their discs have degenerated back, if you like. They may well have had some injury to the nerve, but there is no surgical target that would be of any utility to address. And so these are actually almost primary back, neuropathic back and leg pain patients who do extremely well with spinal cord stimulation. Of course, we've never done the clinical studies on that because we've always done them on the most difficult patients, the sort of the ones who have been to all of these different therapies. But that's one of the challenges for the future, is bringing spinal cord stimulation, I think, up earlier in the disease process. So really, I think it's like if somebody has got neuropathic pain and it's been going on for more than 6 months, despite modest, appropriate treatment strategies, then they should be referred. So that's what I would say. Any other questions? Of course, you know, the other difficulty is that spinal cord stimulation has more than one indication. So here we are talking about chronic neuropathic pain, and we typically often, the commonest is back and leg pain. But we also use it in ischemic pain syndromes. So, you know, it can be used in chronic refractory angina. The NICE guide, and in chronic critical limb ischemia. And the NICE guidance, the quality of the studies wasn't sufficient enough for them to mandate the use of spinal cord stimulation within the NHS. And unless it is part of a robust clinical study. And I'm pleased to say that my colleagues and I have actually commenced a feasibility study in refractory angina, which is just starting. We just recruited our first patient. And that is actually funded by NIHR. So that will be actually the first funded spinal cord stimulator project, I think, in the world, publicly funded in the world. So that's one of the things as well, when it comes to thinking about spinal cord stimulation and in the definition set and all this thing, is that where it should sit? Because you know, we can also apply it, as I say, to, you know, vascular ischemic pain, even to visceral pain, people with chronic pancreatitis, and so on. So, you know, neurostimulation generally should have a great future in pain medicine in the future. It's very much responsible, I think, for changing the way that we're looking at these conditions that we just used to think of in a particular way. So, you know, the spinal surgeons would always think of neuropathic leg pain as a compressive phenomenon, that there would always be a compression. And then would do an MRI and then be rather surprised that there wasn't a compression, and then would, you know, often, you know, come up with sort of other ideas. But it always led to a mechanical solution, if you liked, to the nerve root decompression. And the point is that concept has changed. And certainly my spinal surgeons around us seem to have recognized this. They're not doing revision nerve root decompressions, usually unless they've sent them through me first. Not necessarily for spinal cord stimulation, but see if I can help them. And if they, with, you know, injection treatments and so on. And if I can't, and if they are feel confident that they can help them with a decompression, they go back to them. And then if they fail that, then they would obviously come to us. But at least now they're getting seen by somebody sooner. So if they're obviously neuropathic, then we go straight to spinal cord, well, you know, the anti-neuropathic algorithm and then spinal cord stimulation. Any other questions? I can think of. Open and shut case. Why aren't we doing it? I think the other thing is that there's I think there's 36 centres only around the country that practice spinal cord stimulation. Is that right, Adam? About 36, I think. There's about 10 of them perform about 40 or more cases a year. Probably about 20 between 10 and 40, and the rest less than 10. There is guidance by one of our societies that really doing less than 10 is not enough to maintain skills. Certainly, my history over 20 years, because it is an interventional technique, the technologies have improved, but complications were a little bit higher. But now, complications in our hands are very low. Infection used to be the problem, but now our infection rate is about 1%, which is, for superficial implants, very low. Neurological harm is very, very unlikely, except for sometimes with the neurosurgically placed electrodes in the cervical region. But even then, it's still low. So it is a low morbidity procedure, and as I say, the neurosurgeons like to do them as day inpatients, but most of us in anaesthetic background trained tend to do it all as day cases.
What's the training requirement for the surgeon to do this?
Yeah, that has not been described in our country yet. The Faculty of Pain Medicine, which is part of the Royal College of Surgeons, anaesthetists, is trying to produce, if you like, some requirements. In the USA, they've sort of gone ahead and done that, and it starts off with something like about 15 supervised lead placements, and then then another 15 cases done sort of on your own and that sort of thing. Obviously, when you think of, because making the pocket and the tunneling under the tissues is not something you would think would be automatically within the skill set of anesthesia. So obviously, a lot of people will start with much like cardiologists are putting pacemakers in, they can do a practical surgical course, fairly straightforward.
Is there a certification for that?
No.
As a spinal surgeon, do you think I could do it?
I'm sure you could do it. I think that the issue is whether I don't know your setup, but if the setup should be that there is a multidisciplinary team to make sure that there is a good selection. Because there is nothing worse than getting a patient who is long-term and distressed with their symptoms, who's made lots of chronic behavioral changes, and you kind of come up with the bright idea of putting in a spinal cord stimulator, and you just basically perpetuate a lot of the disability if you do that. So selection and then support afterwards. A lot of these patients are very disabled, have been very disabled. I had a man who'd spent 10 years lying on his belly looking out the window. Now, if you take somebody like that, relieve their neuropathic pain so they can walk again, you've got a lot of deconditioned, if you like, core muscles and God knows what else. So, some of these people do need a lot more sort of multidisciplinary support. And it's just whether the surgical algorithm, management strategy, care pathway would provide that. But physically, there's no reason why you couldn't do it, obviously. I think the neurosurgically placed plate electrodes is a technique that will go out of fashion. I think, it is still being done by quite a lot of our neurosurgical centres because that's what they do. I don't think ultimately it's in the best interest of the patients. I think less invasive is what's in the best interest of the patient. So if you did take it up, I'd ask that you did the less invasive technique. Okay.